Welcome to my today's classroom. In my today's classroom, I will be discussing about acute pancreatitis. Now, this acute pancreatitis is a very common disorder, and in this disorder, usually the patients present with severe abdominal pain. This abdominal pain is so much severe that the patient gets up, down, and rolls down in the bed. Now, this acute pancreatitis is a dreadful condition, and in these cases, mortality can even occur before hospitalization. One of the commonest causes of this acute pancreatitis is alcoholism. So, whenever a patient is presenting with severe abdominal pain and if he is alcoholic, first rule out acute pancreatitis as the cause of severe abdominal pain. Now, these patients they present with severe abdominal pain, and the abdominal pain is sometimes associated with vomitings. Now, the patients, if you are getting history of alcoholism in these patients, then it is definitely the cause of acute pancreatitis. Though there are many other causes, these causes must be ruled out from the historical evidences. Other causes of acute pancreatitis are gallbladder calculus, choledocholithiasis, that is stone in the bile duct. So even the microlithiasis can cause the acute pancreatitis. These stones can migrate from gallbladder, bile duct in form of microstones, microlithiasis, and they are transmitted to the pancreatic duct where they will cause acute pancreatitis. So if there is any such history of gallstone, that is cholelithiasis, choledocholithiasis, then this can be one of the cause of acute pancreatitis. Apart from this, in history, one must rule out any history of acute jaundice. In acute jaundice, in hepatitis A and in hepatitis E, usually the patient may go in acute pancreatitis many times. Usually a patient above the age of 15 years, if they are having acute pancreatitis A, then in those cases patients may develop acute hepatitis A, then these patients may develop acute pancreatitis. So if there is any evidence of jaundice, acute hepatitis A, then it should be ruled out. Now, these patients of acute pancreatitis can even occur in some congenital disorders. One of the congenital disorders is pancreatic divisum. That is, pancreas is divided into two parts. One is the ventral part and the dorsal part. Usually the ventral part is drained by duct of Wilson, and the dorsal part is drained by duct of Santorini. When there is pancreatic division, then in those cases the two ducts they don't join each other, as a result of which both of the ducts they are overloaded with pancreatic secretions, and the bile duct secretion also regurgitate back towards the pancreas, and this can many times lead to acute pancreatitis. Apart from this, if there is any evidence of hypertriglyceridemia, any evidence of hypercholesterolemia, even in those cases, patient may develop acute pancreatitis. So, whenever a patient is presenting with acute abdominal pain, and if you are suspecting acute pancreatitis, then first you will have to rule out alcohol. Number two, you rule out any congenital disorder like pancreatic divisum. Then rule out any evidence of hypercholesterolemia, hypertriglyceridemia. Rule out any evidence of gallbladder stone, cholelithiasis, choledocholithiasis. This must be ruled out from the history. Many a times, in cases of tumors of bile duct and in even tumors of ampulla of Vater, there is overloaded bile duct with biliary secretion, and these biliary secretions they migrate towards the pancreas where they activate the enzymes and lead to acute pancreatitis. So one must think on these lines whenever a patient is presenting with acute pancreatitis. Apart from this, rarely the acute pancreatitis can occur in some viral infections also. So if there is history of viral fever for 5 to 6 days, a simple viral fever, even with simple viral fever because of cytomegalovirus or any other virus can lead to acute pancreatitis. Even Mycobacterium tuberculosis can cause pancreatitis. So these all conditions must be kept in mind to rule out acute cause of the acute pancreatitis. And if you are not getting any cause of acute pancreatitis, that is known as idiopathic pancreatitis. So these are the conditions which usually lead to acute pancreatitis. Whether any cause any cause of the pancreatitis is there, then you will have to work up for acute pancreatitis to make the final diagnosis. In the final diagnosis, the most sensitive marker of acute pancreatitis is serum lipase. So serum lipase must be evaluated. If serum lipase is elevated more than 2 times or thrice the normal, then the diagnosis of acute pancreatitis is confirmed. It is definite. Another serum marker is serum amylase. Serum amylase is also elevated in cases of acute pancreatitis. It is also a sensitive marker, but the serum amylase is elevated in many other conditions. If there is acute salivary gland inflammation, or if any tumor is there in the salivary gland, even then also the amylase is elevated. Apart from this, if there is any tumor of ovary, or if there is any tumor of uterus or fallopian tube, in these cases also the serum amylase is elevated. So it is not a specific diagnostic the diagnostic investigation for acute pancreatitis. Lipase is more diagnostic in the cases of acute pancreatitis. So whenever a patient is presenting with acute pancreatitis, severe abdominal pain, one must immediately go for serum amylase and serum lipase level. Apart from this, you will have to do clinical examination. The clinical examination is must. So you send the sample for serum amylase and serum lipase, and then immediately you go for the clinical examination. Now, this acute pancreatitis is a dreadful condition, and it affects each and every part of the body, not only abdomen. So one should thoroughly examine the whole of the body. Each and every system is affected. Nowadays, usually, if there is acute pancreatitis and if there is a gastroenterologist, he will think only on the lines of abdomen. So one should be cautious, physician must be cautious, gastroenterologist must be cautious, and should examine each and every system of the body thoroughly. Now these patients of acute pancreatitis, sometimes they present in a shock state. Systolic blood pressure goes down below 90 millimeters of mercury. This is because of activated enzymes which affect heart and cause sudden cardiogenic shock, and blood pressure falls down. So this should be managed immediately. So heart is affected in acute pancreatitis, so it should be thoroughly examined. It may cause myocarditis, it may cause pericardial effusion. So this examination of cardiovascular system should be done immediately. Apart from this, it may affect lungs. Patient may go in ARDS, acute respiratory distress syndrome. Again, this is a condition in which mortality is very high. So if in acute pancreatitis, if heart is affected or lungs are affected, then mortality is very high. So immediately one should thoroughly examine the cardiovascular system, thoroughly examine the lungs. Apart from this, sometimes patient may go in renal failure, so it should be managed. Creatinine will go about 2 milligrams per dl. So the management of renal failure should be done immediately in the cases of acute pancreatitis. In acute pancreatitis, the patients may present with hematemesis, they may present with melena, and this is because of gastrointestinal erosions. Acute erosions can occur in pancreatitis. So if a patient is presenting with severe hematemesis or melena, you go for upper GI endoscopy to rule out any gastric erosion, and you will have to treat patient on those lines. Now the patient of acute pancreatitis, whenever he presents in the ward after going for the investigation and physical examination, and first you should go for serum testing of serum amylase and lipase. Then in the next step, when patient is settled down, you go for the CT scan of abdomen and ultrasonography. Ultrasonography is the sensitive test for acute pancreatitis. In these cases, pancreas is swollen, and sometimes there is peripheral inflammation in the fat of which is surrounding the pancreas. So you go for ultrasonography. In ultrasonography, pancreas is bulky. You can evaluate ultrasonographically acute pancreatitis, and then you can correlate it with the serology. Then you can go for CT scan of whole abdomen without contrast and with contrast. In without contrast, CT scan of abdomen is done. Then you can classify into 4 grades. The findings are classified into 4 grades: grade 1, grade 2, grade 3, and 4. It is also known as grade A, B, C, and D. In grade 1, that is A grade, the CT scan is totally normal. Pancreas is not edematous, it is normal. In B, that is grade 2, the pancreas is swollen, but the peripancreatic fat is not necrosed, it is not inflamed. Only pancreas is bulky and swollen. Then in grade 3 or C grade, the pancreas is swollen, edematous, and the surrounding structure, surrounding fat is inflamed. There is effusion in the surrounding fat, and there is a peripancreatic fluid collection. This peripancreatic fluid collection, if it is present, then it is suggestive of grade 3 pancreatic CT scan finding. Then comes the grade 4. In grade 4 variety, the pancreas is edematous. Apart from this, there is surrounding ascites, which is known as pancreatic ascites. Now, as we go in CT scan finding from grade 1 to 4, that is grade A to D, the prognosis is gradually falling down. It goes high, mortality goes high, prognosis gradually deteriorates. So like this, in investigation, the first thing which you will have to do is ultrasonography of abdomen, and then for CT scan of abdomen. Apart from this, the simple chest x-ray, with the help of the simple chest x-ray, you can see that whether there is any fluid collection in chest or not, that is whether there is any pleural effusion or not. Usually in these cases, there is right-sided pleural effusion because of pleuritis in cases of this acute pancreatitis. Now, as more and more organs are affected in this pancreatitis, acute pancreatitis, mortality goes very high. So this is a dreadful condition, and each and every step should be managed in a proper way. In case of acute pancreatitis, there are usually 2 score systems. One is Apache score system, which is the authentic system for marking out the prognosis. But usually in the clinical practices, we don't apply this Apache system. It is very difficult to apply this Apache system, the Apache 2 system. So usually we evaluate mortality and explain patient on basis of the clinical findings and clinical symptoms and on investigations. So CT scan and ultrasonography and serum lipase levels, these are the investigations which can through which we can assess the prognosis. Now these patients, why in these patients the patient develops pancreatitis, why there is severe pancreatic inflammation? It is usually said that this is because of activation of trypsinogen to trypsin. This trypsinogen to trypsin is usually activated in the cases of alcoholics, and this trypsin further stimulate the complement and other enzymes which cause the destruction of pancreatic capsule. Enzymes further leak in the system of the body, and they cause the inflammation throughout the body. So usually this trypsinogen to trypsin and activation of enzyme, there is multi-organ failure. So whenever there is a multi-organ failure in cases of acute pancreatitis, the prognosis is poor. Now as soon a patient enters the ward with acute pancreatitis, how to manage this patient? Immediately you put Ryle's tube and aspirate all the gastric contents so that further stimulation of pancreas is ceased, it is stopped. So immediately you remove all the secretion from the stomach. Keep patient nil orally till further instructions. And keep IV lines patent, and whatever calories are to be given, they should be given on IV basis. Now, in these patients, you immediately start with broad spectrum antibiotics, so that as patient in these cases they become immunologically compromised, they are immunocompromised, so any infection can occur even in pancreas. So to prevent that infection and to eradicate the infection, start with wide spectrum antibiotics, wide coverage antibiotics. So you keep patient neurally, start with antibiotics. You can start with proton pump inhibitors so as to stop secretion of acid, which may cause further erosion in the stomach and clinical condition may deteriorate. Even sucralfate, if it is given orally, this can prevent the gastric erosions which can occur in acute pancreatitis. So these patients of acute pancreatitis should be managed in this way. Now, you will have to evaluate the patient daily by clinical examination of enzymes, lipase, amylase. Ultrasonographic examination should be done daily, and if you are not doing it daily, then you cannot evaluate it in a proper way. So classically in the treatment, you will have to do ultrasonography daily in these cases. Now, as the patient's pain subsides, this will subside, you will have to give painkillers, you will have to give morphine like agents to subside the pain. So usually we give contramole in these cases, and this contramole helps a lot in the cases of this pain in management of the pain in acute pancreatitis. Once pain subsides and enzymes are gradually going down, then you can start with sips of water. You remove the RT, and this takes 5 to 7 days for the subsidence of the inflammation of pancreas. So you will have to keep at least 5 days nil orally. You cannot give anything orally for at least 5 days. And after removing RT, when you start orally, again you will have to assess the patient daily with the help of serum lipase and amylase level and symptoms. If on taking orally, if patient develops pain in abdomen and again lipase and amylase rises, then in these conditions immediately again stop the oral feeding and start IV fluids and RT suction. So sometimes in acute pancreatitis, patient may have to hospitalize for a month or more. You may have to keep patient nil orally for 15 days, even 20 days in severe necrotic pancreatitis. So these patients should be hospitalized and managed in this way. In follow-up, when patient comes to once patient is all right, you can discharge that patient on oral feeding. Oral feeding should be in parts, not at a time, and you will have to give enzyme preparation, pancreatic enzyme preparation in large doses to these patients, because their pancreas is weak, it is not secreting enzymes, it is destroyed. So in these cases, you will have to give pancreatic enzymes orally to digest the food material. So in the follow-up, again, you will have to assess sonographically and by CT scan condition of pancreas, and you will have to monitor serum enzyme levels regularly, lipase and amylase regularly. I usually follow up the patients every 7 days in acute pancreatitis after discharge from hospital. In the follow-up, you will have to watch whether the patient is consuming alcohol or not. You will have to say that even a drop of alcohol will be toxic to you. If they understand your they understand you, then they will stop taking alcohol. If they don't understand you, then again they will get admission as a case of acute pancreatitis repeatedly. And in these patients, complications like chronic pancreatitis may develop. So you will have to watch for complications of chronic complication of pancreatitis after subsidence of this acute pancreatitis. So one of the commonest complication is chronic pancreatitis. In this condition, patient will become diabetic. So you will have to depend on insulin for the management of diabetes. So chronic pancreatitis is one of the condition which is the complication of acute pancreatitis. Apart from this, pseudopancreatic cyst, that is collection of fluid in the sac around stomach and pancreas, may develop in these patients. They may develop acute pancreatic abscess in acute pancreatitis. Again, this is a dreadful condition. Multiple abscesses can develop in pancreas in cases of acute pancreatitis. So these are the complications of acute pancreatitis which must be followed up in a proper way. In acute complications, I have already talked that the patient can die because of multi-organ failure, patient can go in renal failure, can go in acute cardiogenic shock and death, patient can go in acute respiratory distress syndrome, ARDS. So these all complications, acute and chronic complications, should be managed accordingly. Overall, the prognosis in cases of pancreatitis is not good if patient is not following your instructions. So this is all about acute pancreatitis in general, which is followed in clinical practice. Apart from this, there are many other investigations which are to be done in acute pancreatitis, but they cannot be done on the routine way. One is estimation of serum trypsin level and trypsinogen level, which is not widely available. So whatever I have told you in this lecture, those investigations are usually done in these cases. Thank you.